Dr. Boris BRKLJACIC. Sorry, I can't pronounce the name correctly. But anyhow, Dr. Boris is a past president of the European Society of Radiology, General Secretary, International Society of Radiology, President of the European Alliance for Medical Radiation Protection Research, the EuroMed, Chair ESR EuroSafe Imaging Initiative, Vice Dean of International Cooperation, Full Professor of Radiology, Chair of Radiology, Cathedra, University of Zagreb, School of Medicine in Croatia, Chair of Department of Diagnostic and Intervention Radiology, UH Dubrava in Zagreb, as well as the Chair of Advisory Board of Ministry of Health of Croatia for National Breast Cancer Screening Program. His presentation will be in imaging of the breast after oncoplastic surgery. Dr. Boris, the floor is yours. Thank you.
Thank you very much, Professor Salim. Good. Slides are finally here. So I will try in 15 minutes to do presentation on imaging of breast after oncoplastic surgery. It's quite hard to do it in 15 minutes, so I will try to be very fast. So basically, imaging in postoperative breast is used to differentiate residual or recurrent cancer versus scar and benign changes, and as mammography and ultrasound are often inconclusive, MRI is the best imaging modality to do this. Now, regarding oncological surgical methods, now most commonly used procedure, as we all know, is breast-conserving surgery or quadrantectomy, and then there are still some mastectomies with reconstruction using prosthetic implants or autologous myocutaneous tissue flaps like latissimus dorsi, transversus abdominis muscle, deep inferior epigastric, and also there are often reduction mammoplasties in this setting. Now, immediate postoperative evaluation of residual disease after breast-conserving surgery is important if we have positive margins at histopathology, and MRI is excellent to diagnose residual cancer. And then these patients we need to follow up regularly, and we need to do long-term surveillance to detect ipsilateral or contralateral breast or axillary recurrence with the risk of 10 to 15% within 15 years. Now, in cases of unreconstructed mastectomy site, usually the recurrence is detected by physical exam, and mammography is useless in this setting, so we do only ultrasound and MRI. And this is an example of a 58-year-old woman who had mastectomy of the right breast 10 years ago. Mammography and ultrasound of the left breast are normal. This is B-mode or grayscale ultrasound of the thoracic wall. 10 years after surgery, we see this small mass of only 5 millimeters, which is vertical. On shear wave elastography, it's very stiff. And this is corresponding MR, where we see enhancing mass here. So with the, of course, washout type of dynamic curve. So taking all this into account, these are this stiff irregular hypoechoic mass, which is enhancing on MRI. With washout curve was invasive cancer recurrence 10 years after surgery with the same histopathologic features like initially. We can also see, like in this case, contralateral recurrence after mastectomies with this woman who had 10 years ago grade 3 invasive ductal cancer. She has this recurrence, which is again stiff on shear wave elastography, which is very useful. Much more commonly, what we need to look is imaging after breast-conserving surgery, which combined with lymph node mapping to decrease number of unnecessary dissections of axillary lymph nodes, and is followed by radiotherapy and chemo and hormonotherapy, is currently the established treatment of small breast cancers. It's performed when the entire breast cancer can be resected with good cosmetic results, so the role of imaging is important to evaluate breast size, location of tumor, extent of breast cancer, and incision site. And we know that breast-conserving surgery and mastectomy basically have the similar local disease control and survival in patients who have smaller breast cancers than 4 centimeters, regardless of the status of lymph nodes. However, after breast conserving surgery, in many cases residual tumors remain in the breast. Studies long ago have shown that around 1/3 of patients who had residual disease identified who underwent re-excision, and even if there is a free tumor margin, some patients may harbor additional breast foci in the breast. And we know that regarding the residual postoperative disease, if we have positive margins or residual tumor calcifications, we should proceed to MRI and look for clumped, bulky, irregular, or other enhancement extending from the postoperative seroma. Let's see some examples. This is a young woman who had breast conserving surgery in another hospital. She had preoperative MRI there, and then MRI 6 months after surgery. This was grade 2 invasive ductal cancer, HER positive, and then she was referred to our hospital after postoperative MRI. This was preoperative MRI with large enhancing cancer in the left breast. On a postoperative MRI, she had large seroma, which is T2 positive, but she had still this enhancing mass medially to seroma, which was residual cancer, which was not actually removed. This is the ultrasound image with stiff area. We performed, of course, a core biopsy, and this was residual cancer. Another example of 28 years old woman. These are all relatively old examples because now the imaging has improved over the last years, I have to say. This was 28 years old girl in whom operative biopsy was performed for 2 masses in the right breast without actually proper preoperative imaging, and they found grade 3 invasive ductal cancer. They mismanaged it and thought it was fibroadenoma. This is postoperative seroma, and on contrast enhanced MRI, enhancing lesion, which is vertical, irregular on ultrasound, and this was residual high-grade cancer. Unfortunately, she died. Much more common problem is imaging of the recurrent cancer after breast conserving surgery. We know that these are tumors that reappear after cancer treatment. We can have local recurrence in ipsilateral breast, skin, thoracic wall muscles, or lymph nodes. And it's, of course, increased risk for metastatic lesions and poor prognostic factors if patients have recurrent cancer. Recurrence rate is around 5 to 15% after mastectomy within 10 years and 10 to 22% after conserving surgery. They are more common in patients who are young with high-grade cancers, and they are more common if adjuvant therapy was not administered. Those local recurrences might require radical mastectomy or excision of part of thoracic walls with then adjuvant radio and chemotherapy. Now, using mammography and ultrasound, it's very difficult to differentiate recurrence versus scar. They look the same, both on mammography and ultrasound, and findings are often inconclusive. And we know what happens in the course of time with changes on mammography and ultrasound regarding edema, regarding the thickening of the skin, which gets smaller and smaller. However, we can have development of calcifications and large scars and fibrosis. Edema also gets smaller over time. So post-radiotherapy, those changes may remain stable or decrease within 3 years. If you have progressive edema, this indicates alternative changes. Now we do mammography and ultrasound after breast conserving surgery, first mammography shortly after, for instance, excision of ductal cancer in situ to ensure complete removal of microcalcifications. Then 6 months after for the new baseline, and then we continue to resume annual screening after a year. On ultrasound, we see this surgical cavity, which is initially clear hemorrhagic fluid, and then over time internal septa and fibrous bands develop, and they reduce usually until a solid scar would form. However, with ultrasound, it's very hard to differentiate scar versus recurrence, they look the same, and sometimes even scar may look stiffer than the recurrence. This was a case of recurrence 8 years after breast conserving surgery. So the role of MRI there is huge. And although it's not really recommended by many articles and guidelines regarding the influence on further policy, we do know that after breast conserving surgery, enhancement may persist for 18 months. Usually it's weak after 9 months, and I would say that 9 months is a good threshold, because 10 months after therapy, the enhancement slowly weakens. However, certain degree of enhancement may be present much longer, and we need to look in postoperative breast MRI basically for 4 patterns of changes. One is cavity wall seroma, which is T2 hyperintensive, and then on contrast-enhanced post-subtraction sequences, we look at this thin linear pattern, or mass, which in this case is irregular with rapid enhancement and very irregular borders, or this is type 4 of lesions that we see here, which is typical for fat necrosis that can also be seen in breast reduction surgeries. So in a large paper that Mary Mahoney published a few years ago, they looked at over 150 patients after breast conserving surgery, and they have seen that enhancement might be present in 40% after 18 months, and that this type 3 of mass enhancement with washout kinetics and irregular borders is most predictive of recurrence, and that basically these patients should be, of course, biopsied and these tumors re-excised, while this is typical fat necrosis, and this most commonly isn't cancer. Let's see some examples. This was a 46-year-old woman who had breast conserving surgery of the left breast, as you see, 15 years ago when she was very young. It was very high-grade invasive cancer, grade 3, with positive axillary lymph nodes. On mammography, you wouldn't really suspect something because this is scar, this is craniocaudal images, again, quite dense breasts, but basically you don't see much. However, on ultrasound, this is 15 years after surgery, vertical hypoechoic lesion with irregular borders that is quite stiff on shear wave elastography, but when you do MRI, there is absolutely no doubt that this is enhancing mass with irregular borders, with plateau type of kinetic curve, and biopsy has shown again grade 3 cancer with 30% Ki67, so quite aggressive ipsilateral recurrence at the site of surgery. This is an example of 80-year-old woman who had breast cancer 22 years ago, and she has now large recurrence exactly at the site of the scar, which was ER and PR negative. At that time, HER2 was not determined long ago, so basically we can really see these recurrences even very, very long time after the initial cancer was resected. She had very hypervascularized color Doppler finding with penetrating internal vessels and very stiff on elastography, so also ultrasound is very useful in this case because scars do not look like this. Regarding the screening of women with prior breast cancer, there were several papers that show that this is actually useful. We do MR imaging for women with high risks, with BRCA1 and 2 positive, who have risk of getting cancer over 20 or 25% over lifetime. However, in these papers, it was shown that basically if doing MR screening in women with prior cancer annually, the figures of cancer were more or less equal or even higher than in high-risk group of women. So it was published already 10 years ago that if you compare women with a group of women with genetic and familiar predisposition, that basically with MRI you see more findings either cancers, invasive or in situ, or high-risk lesions in the group who previously had breast cancer. So this gives rationale to actually use MRI in screening of these women who had previous breast cancer. This is an example of less common case of recurrence in 73-year-old lady who had breast cancer 8 years ago and underwent radiotherapy, and now she has angiosarcoma with this huge enhancement in conserved breast. It's very rare, but it can happen. This is most malignant of all tumors, which is known that can develop 3 to 11 years after radiation and may be direct consequence of radiation. And then there are, of course, typical findings of fat necrosis that are benign changes that we need to differentiate from cancer. We know that fat necrosis is a great mimicker and can be found also after percutaneous biopsy, but we also see it very commonly after reduction mammoplasties, and we need to recognize a typical MRI pattern of fat necrosis. Finally, just for the end, few words about imaging for recurrent cancer in reconstructed breast, either using prosthetic implants or autologous tissue. This is a woman who had cosmetic breast augmentation 25 years ago. She came worried that she has rupture of implants. This was her ultrasound of both breasts, clearly no rupture, but bilateral invasive lobular carcinoma. We hardly convinced her that she needs contrast-enhanced MRI, and she, of course, had to undergo bilateral surgery immediately. With myocutaneous flaps, there are really different types of flaps. Now, deep inferior epigastric and superior inferior epigastric artery flaps are mostly used. They are on imaging on MRI very dark and lucent. Basically, on mammography, recurrences resemble primary tumor. The same is on ultrasound. But MRI is again the best, with masses with irregular shape and avid early enhancement. This is an example of 41-year-old lady who 3 years ago had reconstruction of left breast with myocutaneous flap due to triple negative high-grade cancer. And this here is recurrence, which was also very stiff on shear wave elastography and was confirmed with the core biopsy. This is another example of a 49-year-old woman who had left breast reconstruction 2.5 years ago for triple negative cancer. This is recurrence, and this is cancer in contralateral breast, which was not operated, so she had recurrence both in myocutaneous flat and cancer in the right breast. And certainly if you see those stiffer lesions on ultrasound, if you do second look ultrasound after MRI, they should be considered suspicious, and elastography might be a helpful tool in a if this is related to restricted diffusion on MRI scans. And this is last slide. Basically, most of the findings we see on MRI after reconstruction with myocutaneous flaps are actually benign. Minority are cancers, so this we have to bear in mind. So this was a very short presentation of post-oncoplastic findings, where MRI is apparently the most important modality. Thank you very much for your attention.
Thank you very much, Professor Boris, for such a wonderful presentation, as usual. And now I'll call on our next speaker, who just arrived.